Sure. So welcome, everyone. I'm going to just go ahead and present my screen. We have put together just a brief PowerPoint here so that we can give you guys some additional information here on how and why these new protocols came to the Children's Cabinet and were passed by the Children's Cabinet back in December. The first thing I wanted to do is just really talk about, our goal of, and when I say our goal, I'm talking about the Children's Cabinet and child serving agencies as a whole, and really improving on the services that we're providing children and families. And everything that, we do has that as the #1 priority. And we know from sort of dealing with additional issues that have come to the forefront from the legislature, from the public, from a number of different places, that there were some concerns with regard to how services were being provided, mainly to very high intensive or intensive needs kids throughout the state. So having said that, I just want to make sure that we're all on the same page, and that our goal at the state level, as well as sharing that and collaborating with folks at the local level, is to really put the priority and the needs of families first. And through my conversations with all of you, I know certainly that was on your priority list as well. The goals that we have today for the presentation, they're really threefold. And we broke this down so that we could sort of take individual sections on what was sent out to you guys back in December. And so the first thing we're going to do is talk about the actual directive that came out, sort of the thought behind it, the purpose behind it, and how the purpose is sort of what the intent of it is to focus the role of the LCTs and the LCT coordinators for certain populations. Second, we want to take a look at the referral form that was put out. I know there were a lot of questions submitted with regard to that. Specifically, the purpose behind that was to promote uniformity throughout what the jurisdictions, were collecting, what information they were gathering, so that everyone is on the same page. And if, additional communication needs to be had, that we're all using, the same information, so that we're all on the same page. Should we need to reach out to someone else, everybody's files, should be in order in terms of anybody could take that, information if they need it and would be able to use it without sort of having to go back and start from scratch or, make a ton of additional edits. We also wanted to talk about sort of the flexibility with regard to parents and self-referrals. I know that there, again, were a lot of questions surrounding the form and how it was too complicated for families and too complicated for maybe those adolescent kids that might be coming to your tables or calling for assistance. So there's a lot of clarity that we can provide on that as well. And additionally, third, we wanted to talk about the directive that came out, or essentially, the protocol with regard to hospitals and local care teams, and how we're hoping to improve the partnerships there. And I know a lot of you indicated, certainly in the questions and even during the interviews, that it's often difficult to communicate with hospitals, and there's not that, uniformity. And if, staffing changes are made at a hospital, you might not have the relationship that you once had. So, sometimes you guys are starting off behind the 8 ball because these cases are coming to you, far after, a child has, would have benefited from a real coordinated effort at a local level. So, we want to talk about that and how we can move forward in developing that partnership. We started out, and I really wanted to address this from the standpoint of, the interviews that I conducted and the conversations that we all had with regard to a number of issues, and how this all of this sort of came out of that. So, as I explained when I got on the call with each of you, the Children's Cabinet had put together what we were calling a hospital overstays team, and the hospital overstays team was directed essentially, number one, to sort of dig in and find the scope of what was going on, the number of kids, the problems that we were seeing in hospitals and why kids were overstaying medical necessity, and then sort of really look at the larger scope of the issue, which included, are we not just having problems, finding placements or finding services for kids that are in the hospital, but we also have a clog in RTCs, and we can't get kids out of the hospitals because we don't have spaces in the RTCs. And we can't get kids out of the RTCs because we don't have treatment foster care or other community-based services that could appropriately address those needs. So as we started this back in the summer, it became, very clear that we, number one, had an immediate situation that we needed to address, which was those kids that are today or that were at that time literally in a hospital, unable to find placement, and then taking a look at the broader scope and taking a look at the system as a whole and how we could make some improvements to that. The hospital overstays team was essentially created, like I said, because of the public concerns, but there was also, and I'm sure many of you know, legislation that was presented, I believe it was last session, that really would have impacted a lot of the work that was being done by the various child serving agencies, and it really would have made things very difficult. And it was all geared toward kids that were overstaying medical necessity inside of hospitals. So as the cabinet worked to try to talk with the legislators about that particular bill, it became clear that we could create a team to really take a look at this and see where we could make some improvements. So that action started in the summer of this past summer. And again, the Children's Cabinet implementation team, when we sat down and formed this separate body to really dive into this work, it became very clear that local care teams were incredibly valuable and incredibly vital to the work that really needed to be done with regard to the kids that are exhibiting these intensive needs. And so the Children's Cabinet implementation team directed our office, as we are staff to the CCIT as well as the cabinet, to go out and talk to local care teams, number one, to find out what barriers they were facing, number two, to see what kind of policies and procedures were in place to deal with kids with these types of intensive needs, to talk about what types of cases they were seeing, what types of cases they were hearing, and just sort of overall how local care teams were functioning. And, it became clear very early on that as those interviews sort of progressed, that there were a lot of rumors going on throughout the local communities that, the Children's Cabinet was looking to take local care teams and put them under DHS, that the Children's Cabinet was looking at, potentially defunding coordinators and making, those types of changes, that local care teams weren't important. And so when I got on all of those calls, I wanted to make it very clear to you all that it was not the intent of the Children's Cabinet to relocate local care teams, and it certainly wasn't it wasn't in the cabinet's plan to make any changes with regard to defunding local care team coordinators. So I understand from the local management board meeting that there seemed to be a miscommunication with regard to my role and what was going on with regard to those interviews. But we were, collecting that information to see how we could, number one, see how the local care teams were operating, and to see how we could use your expertise and your knowledge of your local communities to essentially help in this regard, to deal with the kids with intensive needs. So when we talked to you, there were, it was clear and made clear to me from numerous different coordinators, and it was clear from just taking a look at how things were operating that there wasn't uniformity across the state. And so that's not to say that anybody was doing something wrong or bad. That's certainly not what we were saying. But our goal with everything was to improve service delivery for children and youth and for families throughout the entire state, and getting everyone on the same page, with regard to how we are going to try to really address these intensive needs cases. We saw as a result of these interviews, we identified approximately about 32 cases that were, I don't want to say they weren't necessarily in a hospital, some were, and then other kids were in a similar situation where they were stuck in an RTC and unable to be placed elsewhere, or they were in an RTC and at risk of ejection because of behaviors or whatever the case may have been. And so those cases, we've been able to, some of them, most of them, I think when we met this morning, we said about 17 of them have been brought to the Interagent Placement Committee table. And we've been able to sort of take a look at those cases and see if, what the barriers were, if we could maybe solve some of the, the issues at the state level, or help move things along a little bit quicker for the folks on the ground. But I want to reiterate that, the local care teams are, you are the interagency bodies on the ground, and you are the folks that, your families, your communities. And so you are, number one, valued by the Children's Cabinet. And these decisions were made with all of that in mind. And number one, with the children and families and priorities, and understanding that you all could be the most help to these types of cases that, unfortunately, we keep seeing more and more of in Maryland, and we're trying to figure out a way to address those intensive needs. So, Kim, I can turn it over to you.
Great. Jenny, do you want to just keep sharing your screen so that we're not jockeying back and forth?
Yeah, sure. I'll take care of that.
Great. Thank you. Good afternoon, everybody. So I'm going to take over now and just hit a couple of the highlights. So as you know, the information first went out to local care teams and local management boards, because they administratively house the local care team coordinator at the end of December, so on December 22nd. Yesterday, we did some follow-up information that hopefully made its way to all of you. And so before I start, I want to reiterate that we have, hearing your concerns, we've pushed out the implementation date for the new directive in the form. And so we're asking that if you can implement all or any parts of this prior, that you please do so. But we've pushed out that implementation date to March 1st. And so some of the information, of course, that we'll talk about today will be, in effect for those of you who are moving forward right now, but then also effective March 1st for that. So we put that out. Yesterday, also a little bit later, we put out the first and what's probably going to be a series of question and answer documents. So we've received a lot of questions that we are compiling, answering, and we'll disseminate them widely in the same manner. The idea being, if one of you is asking the same question, probably a lot of you are, and we did, receive duplicates. So if you don't see your question worded exactly the same way, If it's a duplicative question, we're just answering it at one time, and so we're not going to answer every single one separately. So we put out the first Q&A document yesterday. We have another one that's already in the pipeline that we hope to get out to you by the end of the week. And so hopefully that's answered or clarified quite a few things. But in either case, we're going to go through the Q&A document in just a minute. But I just wanted to hit, as I said, a couple of the highlights about what is different now and compare and contrast the past and the present. So if you'll bear with me, so on this slide, we have, in the past, the local care teams were required to only discuss a VPA case, and you could prioritize other case types for review. So the VPA requirement to discuss a VPA case, that exists in statute. And so, of course, you had to do that. But then the local care team had some autonomy to determine what other kinds of cases it would or would not prioritize for review. Now, with this new directive, we're clarifying the roles and responsibilities of LCTs with respect to certain youth. The LCTs have always been a forum for intervening with youth with intensive needs, but we have, or the Children's Cabinet is prioritizing a specific subset of youth for which we definitely want all local care teams to intervene. Also, in the past, the local care teams could use local decision-making to determine how often your meetings were going to be held and how those meetings would flow and what they would entail. With this new directive, number 3, that goes into effect as of March 1st, you can still decide your regular meeting schedule, but there is very specific timely intervention noted for certain youth with complex needs. So again, we're talking about those youth who are identified in numbers 1 through 6 at the top of page 4 of directive number 3. I know that's a lot of mumbo jumbo, but you'll see that referred to many times in the Q&A document and also in our presentation today. Jenny, next slide. In the past, local care teams have the autonomy to develop its own referral form to best suit its needs and the needs of those that are coming to the table. So determining the kind of youth that you are going to review or have at your table, we have 24 different referral forms in use across the state. Presently, or with this new directive number 3, you need to use the standard referral form for certain referrals. So again, for those youth number 1 through 6 that are at the top of page 4 of new directive number 3, you have to use the standard referral form for those youth. For any other youth for which you're going to have at your table, you can continue to use your own form. You could use this new standard form, but we're only requiring the use of the standard form for these very specific subset of children. In the past, local care team coordinators have not been case managers, and there is no change with this new directive. The new directive sets out a very specific protocol for those certain youth, but the requirements that relate to those specific youth are not case management requirements. Jenny? So the universal referral form, it's required for certain populations, again, only for those numbers 1 through 6 at the top of page 4 of directive number 3. You can continue to use your local forms as you'd like. And the idea behind using a standard referral form is that it promotes uniformity and collection of data across the state for certain youth. So if if the Children's Cabinet has prioritized these certain youth that we definitely want all local care teams to intervene with, we'd like to be able to collect the same information about those youth because that's going to aid the state in terms of resource development and also our reporting activities and future policy development. We are not specifying who must complete the form. So a lot of the comments that we've received have been that the form is not family friendly, and it may be, it does include some jargon that is going to be specific only to certain agencies, or it's confusing maybe for newer workers who haven't been around the block as long as some of the others. So we are, and you may have seen this in the Q&A, we're not going to specify who has to complete the form. So in the case of parents, we would suggest, we have suggested that maybe parents just complete lines 1 through 5, and that the local care team coordinator assist the parent with gathering the additional information. But if you, we're just going to leave it open-ended as to who completes the form, as long as the form gets used and gets completed. So if you want to gather information in another manner and transfer that to the form, whatever works best for you. But we're not going to specify who must complete the form. We are saying that the form needs to be used though for that very specific subset of youth. Jenny, hospital partnership. So the idea behind the protocol for the hospitals is that there's a single point of contact for youth in acute hospital settings. We did define hospital settings in the Q&A document that went out yesterday. And the idea behind this is that it's going to promote increased collaboration with the hospitals and would allow for hospitals to start discharge planning in a timely manner. We have, the protocol has been disseminated to the hospital association for use throughout their group. And if you've seen the Q&A, you'll see that we are also doing some targeted outreach to hospitals in other jurisdictions because we know that Maryland is surrounded by other states. If you have relationships with local hospitals, you are more than welcome to outreach to them about this, but you are not required. And by you, I mean local care team coordinators and local care teams. You are not required to do that. Jenny? The question and answer recap. So we're going to switch over and we're going to go through the Q&A recap that was released yesterday. We would encourage you to continue to send questions to Chris Mille, and his email is here. And as I said, we're compiling them, releasing them. We have a document number 2 that is in process right now, and we hope to get that out by the end of the week. But we'll keep compiling questions and answering them as they come in. And we hope that you find that that is helpful. If you send in a question and you don't see it answered in the next recap that comes out, that would mean that we are seeking clarification. So don't feel like we're sort of cherry picking and leaving things out. If we don't have an immediate answer, we're following up with our partners to get the answer for you, and we'll just include that in the subsequent recap. So this is sort of a natural stopping point. So before we move to the Q&As, Chris, do we have any questions in the chat? Chris, are you there?
He's on mute, Kim. I know I saw a couple of questions. Oh, Chris, are you there?
Yeah, I am here. I'm sorry, I froze up for a moment, and I'll go in order. So give me just 1 second to get back. Okay, so will the hospital overstays team be looking at the reduced capacity for RTCs and now diagnostic centers with changes to Arrow over recent years and work to increase capacity / return to our previously available capacity, for example, increased outreach to new providers?
So I'll just start off by saying that the hospital overstays team, the CCIT, and the Children's Cabinet is always interested in affecting increased capacity. It's something that's been on our radar for as long as I can remember, and I would imagine it would stay on the radar. That being said, if we have any agency folks, any CCIT members or others who would like to comment on that, I would open the door for you. Okay, hearing none, let's go ahead and move on.
Next, Mary Leslie asked, and I believe you've answered this, so all questions that are not duplicative will be answered.
Correct.
Also, regarding youth 1 through 6 on the top of page 4, so number 6, self or family, no matter the need of the family, must use the universal referral form. And that's a question.
Yes, if the universal referral form is for youth who are identified in the population 1 through 6 at the top of page 4, correct.
Can I follow up on that?
Yeah, sure.
It's Jan. If you have a self-referring family that is just looking for information, because number 6 is for self-referred, they need to use a universal referral form? Not understanding something
Yeah.
in this 1 through 6.
You're kind of freezing up a little bit, but I think I got the gist of it. I think if you are talking about, and I'm going to use an example that's way oversimplified, but if you have a family that's coming to the LCT or calling the LCT and they need simple assistance like a referral to, like they're new in the community and they're looking for, I don't know, the food bank or something, or wanting to know like who's the local, who's the child welfare agency or something that's very simple, then I think that's a judgment call where you wouldn't use the universal referral form. I think a self-referral for a family whose youth is in crisis, obviously you're going to want to use the referral form, but those simple warm line kind of calls or easy handoffs for, I can't think of the term, those easy handoffs to like a 211 kind of a thing where they're really only looking for information. No, we're not saying that you need to use the referral form. We're not saying that you need to use the standard referral form if it's one of those sort of warm handoff things. So it's really going to be a judgment call on the part of the locals to know, is a family contacting you because their kid is in crisis, or are they contacting you because they need, a simple handoff and they don't know where to turn to in the community because there is no, 211 kind of a thing.
Okay, thank you. So for essentially any family that you're going to bring into a meeting for a review, you need to use the referral form.
Yeah, it sounds like it, yes, for you,
Yeah.
Next.
Okay, working down through, will funding be provided to other LCT member agencies to support increased staffing needs to address the expanded LCT directive?
So individual agency budgets are handled obviously by that agency. So I would refer those respective agencies back to their leadership. I can't comment on another agency's budget. And many times I can't comment on my own, sorry.
Has there been any study to look at the impact of the VPA reinterpretation, for example, removing therapeutic group home access on hospital overstays?
I see Jan shaking her head. I don't quite understand that question. So Jan or Stephanie, if you can interpret that for me.
This is Heather. I had talked with Stephanie if she doesn't have her mic working. Can you guys hear me?
Yeah.
So the question with that was, in recent years, there was a reinterpretation of the VPA policy, which we totally get, and it limited access where you can no longer access therapeutic group home settings through VPA. And so we're following that change directive. I think there's just been some curiosity if that change may have had any impact on hospital overstays. So for instance, maybe some youth who typically could have accessed therapeutic group homes, but now cannot unless they become a CINA, has that changed the, I don't know the right word, but the flow of things in the larger system of care?
Got it. That makes sense. And so for response, I would ask any of my Department of Human Services agency partners who are on the call if they would please take that one.
Tennille, if you're on, could you take that one?
I'm on. I'm sorry. I was trying to come off of mute. Good afternoon, everyone. As it relates to that policy directive, we are in the process of taking a look at that directive. We have seen over the past year where there have been youth that have been either on a hospital overstay status in a hospital or have been delayed in being discharged from a RTC. There has been some alignment with the need for therapeutic group home settings, but we need some more data to really reinforce that outcome.
Thanks, Tennille.
Can GOC give a scenario of each of the 1 through 6 populations?
Do we know what we mean by scenario? I don't understand, sorry.
Susan, could you clarify, please?
Yes. Can you, I mean, I think we're also confused on each one of these populations that, you know, if GOC can just give us a scenario of who that child would be coming to the table.
Okay, hold on, I'm pulling up the protocol now. Okay. Okay, so I'm going to start, and so then I would ask again, agency partners, if you have anything to add to my response, please feel free to jump in. So number 1, currently in or at risk of an extended hospital stay. I think that one is fairly self-explanatory. So you've got youth who are in a hospital and need another placement and have nowhere to go. Number 2, at risk of ejection from a community/residential treatment center placement. So these are kids with intensive needs who are currently in a placement. The placement is threatening, threatening ejection or has a plan for ejection. They need another place to go, and there is no other place to go. Number 3, known or referred to the LCT and are or are not formally involved with an agency who are at risk of a community, RTC, psychiatric, out-of-state placement. So these are kids who everybody around the local care team table knows about, although they may or may not be formally involved with an agency, so they may not be receiving services from the core service agency or have involvement with DSS or DJS, but we know that they have intensive needs and they need a placement and they can't find a placement. No one seems to be able to, and there's not a coordinated effort to make a plan. So this would have the local care team become the place to do some of that interagency problem solving. Number 4, youth whose needs cannot be addressed by one agency. And again, we're not talking about financial needs, and we're not necessarily talking about public school system unless the youths, basically all kids are, the majority of the kids that you're going to come across are involved in the school system. So if there aren't any problems being exhibited at the school level, you wouldn't necessarily, count the school system as one of the agencies, but we're talking about intensive youth who are multi-system involved. So kids who are involved, say, with the core service agency, who've maybe been adjudicated delinquent with DJS and are also involved with the Department of Social Services. I think as you look at the youth that you've intervened with over time, you all know the same kids in the community. I know when I was a caseworker many, many years ago, everybody from all the agencies, we all knew who the most intensive needs kids were in our community. Number 5, youth who are referred by hospital personnel in accordance with the hospital discharge planning protocol. So those are going to be those referrals that the hospitals are going to send to you, hopefully, because they have kids who are in a hospital and they're at risk of a lengthy stay because, again, they have no place to go. And then number 6 would be those that we just talked about, youth who are self-referred or family referred that are in need of something more than a warm handoff or information and referral. Any agency partners, is there anything you'd want to add to any of these, any of those scenarios or any of those populations?
Jen, I believe that was Jen that was speaking. This is Tennille. I want to say the one where you said the Community Residential Treatment Center, are you speaking of the PRTFs in Maryland or the residential child care providers?
Hold on, I got to go back. I have to go back. I had already shifted away. Honestly, Tennille, I don't remember what number I was referencing then.
Kim, I thought it said residential treatment centers. It's number
Yeah.
2, Kim.
Yes, it says at risk of ejection from a community/residential treatment center placement. So at risk of ejection from a community placement and or residential treatment center placement.
Okay, I just wanted to make sure that everybody got the clarification. Thank you.
Sure, no problem. Chris, turning it back over to you.
What is going to happen if LCT mandated members cannot attend meetings because of the 5-day time frame? We have a recurring meeting schedule, and sometimes members can't even attend those. Asking members to drop everything with such a short time frame as a heads up is going to reduce our attendance.
So a couple thoughts on this. One is if the youth, and I'm going to use the local Department of Social Services as an example, if this is really a DSS intensive youth, where DSS is critical to the review and the decision making, then I think there's a difference between having that person absent and having a developmental disabilities rep absent when the youth doesn't have any developmental disabilities. So the 5-day requirement to schedule and hold a meeting was to put some structure into this. Certainly, we would all agree, and we've chatted about this in a couple of different work groups, is that we would rather have a meeting held on day 6, 7, or 8 than not be held at all, or held on day 23 or 3 months down the line. So, and again, being able to meet the needs of the family might not be able to meet within 5 days and might ask that you schedule it on day 7, 8, or 9. We would want you to document the attempt. And if you're not able to hold the meeting in the 5 days, I mean, there's no penalty for not meeting that requirement. We want you to be responsive to the needs of the family and also the needs of the agency. So if you know, again, having a meeting on day 7 with the family and coming together to make a plan for that family is better than not having a meeting at all. And so agency, you know, just to speak for the agencies, and again, agency people step in, please. This isn't a Governor's Office of Crime Prevention, Youth and Victim Services protocol that we put down. There's no email address for the Children's Cabinet, so we send this stuff out on behalf of them, but the agencies are aware of this. They've communicated this through to their staff, and they're aware of the need for this. We don't know what the numbers are going to be going forward. It could be a very small number. Looking at the numbers of kids that are reported in the data for the local care teams, you know, for the last 2 years, you may or may not have large groups of numbers, but we can certainly reassess the timeline sort of in the future if it becomes, you know, truly problematic for large numbers of jurisdictions, and also, or even if it's just problematic for one jurisdiction, you know, we're willing to work with you on this, but we needed to put some consistency and some guide and some standardization out there to try to get everybody sort of on the same page.
All right. This next question is referring to population number 4 on the directives. Is this referring to the list from the Universal Hospital Discharge Planning document? And that is youth with multiple emergency department visits for behavioral health needs, 2 or more hospital admissions in the past 90 days, hospital ED stay of 5+ days without an inpatient admission, responsible for suspected of fire setting, suspected of human trafficking, diagnosed developmental disabilities and or autism, the psychiatric features or unique placement challenges. So is there a link between population number 4 and that list from the Universal Hospital Discharge Planning? So that list would be number 1 on the Universal Hospital Discharge Planning Protocol. And the question is there a connection between that list and number 4 on the directive?
There was no, I'm speaking on behalf of the committee, there was no intentional link there. I'm a little unclear of the question. I'm sorry. If you want to, whoever this question came from, if you want to reach out to Chris with some specificity, sorry, some of these are a little hard to do on the fly. We can certainly follow up in part of the recap with that.
I think the real question regarding meeting attendance is when meeting attendance is low due to inability to meet, what will the repercussions for the LCT and the scorecard be?
Well, honestly, it could, I mean, if you have mandated members that aren't attending mandated meetings, it may affect the data it may affect your data, which is going to affect your data reporting, and you would address that as you always have in the story behind in the scorecard.
All right, can I just provide, I listed number 4 instead of number 5 for my previous question. I apologize. Number 5 on the population is youth who are referred by personnel in accordance with the Universal Hospital Discharge Planning Protocol. So I just wanted to make sure that I was understanding where that list is on the Universal Hospital Discharge Planning Protocol.
Hold on, I don't have that protocol pulled up. Sorry, I left the other one up. So it would be in number 1, in the hospital discharge planning protocol, it's number 1, A through I.
That's what I was asking. I was just asking for that clarity. Thank you.
Sure. Chris, any more?
Yes. For population 2, is it possible to add to these? Is it possible to add to these kids where there is no current plan? We have frequent placement disruptions. However, for the majority of cases, DSS is able to make a plan without utilizing an LCT. I'll try to follow the question.
Yeah, can we maybe get some clarity on that one too?
So in the protocol, it doesn't state specifically that these are, it just says the population of kids where there is about to be a disruption from an LCT or community setting. So that's like, I mean, that's a lot of kids where there's about to be a disruption, but we have an FTDM procedure where we will have, you know, an internal meeting about those kids. And usually we don't have a problem finding another placement for them or preventing the disruption. It's those kids where we have, like, we've tried all of our regular avenues and then still have no plan. So it just seems that this list makes it seem like it's any kid who's about to have a disruption.
So by disruption, do you mean ejection?
Yes, I'm sorry.
Okay. I think certainly if your specific agency, if your placement agency is able to handle that ejection and make a plan, then you should continue to do that. None of this is meant to circumvent individual agency responsibilities and what they're, you know, what they currently have in place.
Kim, this is Kara from the Department of Juvenile Services. Nora, thanks for that question. I think you answered it right. The intent of the committee was not to overstep the internal procedures. I think to clarify that, yeah, if there is no plan, we can look at that and make sure that that clarity is given. So it's really if there is no additional plan for that young person.
Yeah. Great, thanks, Kara. Chris, how many more do we have? Should we go to the Q&A and then come back to these? I don't want to run out of time. Okay,
yes,
great.
I think it would be better.
Okay. Do you want me to share my screen?
Yes, please.
Oh, wait a minute, Jenny already just pulled it up. Jenny, can you make it bigger though? Okay, so we're just gonna start and run down these. So number one, due to the length and the language, the referral form is not family friendly and may result in barriers and challenges. I think I briefly ran through this before. Having that one universal referral form was an intentional decision, and there were a lot of discussions about it. The form isn't new, but was edited slightly from the form that we've been using since 2018 for referrals to the Interagency Placement Committee. So hopefully many of you are familiar with it, and it does have an instruction tab to it. And so I can make sure that when we release it with the edits of to correct some of the issues that have already been brought to our attention, I can make sure that we beef up the instructions a little bit to make it to make some of those instructions more clear for those of you that are just seeing it for the very first time. Number two, when referrals are made in the context of resource consultation, is the entire form required? So this goes back to the comment we said before, that if it's a simple warm handoff or just seeking information, it's a phone call. That's not something that you need to use the universal referral form for. That would be a judgment call. But I think Jan mentioned that in her jurisdiction, any case that they're going to use it sounds like it would be any case that they're going to review would be one that they would use this form for. The form doesn't include tracking or any follow-up fields to monitor the outcome. We didn't mean for the form to be standard for those populations. When we release the Google Forms version, you are free to add fields or add anything that you want to aid in the tracking, as long as you don't delete any of the standard information from there. Number four, certain parts of the form are appropriate for various case types and not appropriate for others. It may result in lots of NA responses. If, for example, for certain youth, if the accurate response is not applicable, then certainly you would enter that. I think I know that for me, when we would get these forms filled out for the Interagency Placement Committee, it's much preferred to have not applicable, so that we know it's been considered versus just having a blank in the form, so we don't know was it a question that was missed. So, you know, not applicable could certainly is a valid response. Number five, should we add the new LCT referral form to our website? That is a local decision. Again, the implementation is a process, so we pushed that, extended that date out until March 1st. You're free to post it or make it available in any way, shape, or form that you would wish. Number six, when I try to access the form, it requires me to have permission. So when we sent the form out on 12/22, that is the final version. You can go ahead and use it now if you want, but it was sent via email as an attachment. It's also on the GOC website. Even though GOC doesn't exist anymore, we still have information on our website because we're still transitioning over. And it's also posted in the LCT Google Drive. Those access issues are related to those who don't or may not have permission to access the Google Drive folder. If you ask for permission, certainly we will grant it, but you can go to the other places and get immediate access without waiting for your permission to be granted. There has been some enhancements to Google lately. It used to be anyone, you could change the settings so that anyone who had the link could get it, but that's no longer an option if people aren't in the maryland.gov domain. So that's just a flaw with Google and Maryland's use of Google. Number seven, will Google form be specific to our jurisdiction? Yes. Number eight, in my understanding that every referral needs to have an LCT meeting within 5 days. Talked about this earlier, that you should schedule and hold the meeting within 5 business days. But again, we'd rather you have a meeting at 7 business days than not have a meeting at all. Are all LCTs to use the new form that was emailed to us, and should we use it in place of our individual form? Again, the referral form is required only for those populations 1 through 6, as noted at the top of page 4. For any other types of referrals or requests, you're free to use whatever referral form that you want, and that would be your jurisdiction preference. Continuing to use consent to release of information. Nothing about what's come out in the end of December impacts or changes the consent forms or use of release forms, so please continue what you're doing. While I think the use of the referral form would make sense for youth who are hospitalized, I'm concerned that the criteria makes it necessary for all youth who are being referred to the LCT. Again, referral form is required only for those populations 1 through 6, and for other kinds of referrals, you may use whatever referral form you choose. Regarding the requirement to have a meeting chair, we've been told that we don't have to have a chair. Has that changed? No. The directive states that they should select a chair and the term and the roles and responsibility in accordance with its local policies. So if it's your local policy not to have a chair, then you don't need to do anything. Regarding the requirement to conduct an LCT meeting within 5 business days, it's not always possible. VPA meetings are held within this time frame because of the 7-day requirement. We discussed this briefly earlier, that the mandated agency members of the LCT need to support that process. The agencies are aware and they were involved in the development of this process, and they assisted in the recommendations that were made. Agencies have been sharing this information with their staff, and they should be aware. Have local hospital teams been given the hospital discharge planning protocol? We struggled with hospitals at some point about what the LCT does, and I'm not confident that we will be able to implement the protocol without their collaboration. That hospital planning protocol was developed in conjunction with the Maryland Hospital Association, and that final protocol has been shared with them. We've been reaching out to the Hospital Association in the District of Columbia, and we're looking for contact info for similar associations in Delaware and Pennsylvania. The protocol outlines the responsibility for hospital personnel to make a referral. And so the protocol really is specific to hospital personnel, what they need to do. Number 15 on page 4, LCT members will be unable to meet the expectation of meeting within 5 business days. I think that's been asked and answered. According to the protocols, essentially all cases will be scheduled for a review within 5 days. Is this intentional? Yes, it should be scheduled and held within 5 business days. But again, we'd rather you have a meeting at 7 business days than no meeting at all. According to the protocols, number 17, all cases where any agency involvement is reported must result in communication up the chain. Is this intentional or by design? Yes, absolutely it is. The idea being that involved agencies will determine what steps will be taken internally, and then we'll seek whatever interagency collaboration is needed on a case-by-case basis. Number 18, please define current involvement with the agencies. Is this meant to include axillary involvement or non-committed youth, i.e. youth and kinship navigation, post-adoptive services, etc.? Current involvement means receiving services from the agency. It doesn't mean instances of youth or their family receiving only family assistance. So if they're receiving food stamp benefits, and that's their only involvement with the Department of Social Services, then we wouldn't consider that to be quote unquote agency involved. The idea behind this is that identifying involvement with the agencies and the requisite notification will ensure some interagency collaboration in a timely manner, because what we're finding is that a lot of times people don't not everyone is in the same page and realizing what's happening with a particular youth at a particular time. What's the goal of the new directive? The goal is to return and or divert children and youth from preventable out-of-home, out-of-state hospital and other overstay placements. That's really what all of this is about. And frankly, you know, we are trying to prevent the possibility of another class action lawsuit maybe in the future. Number 20, does this shift focus of the LCT to direct its efforts towards the type of referrals outlined in the directive? No, frankly, youth with intensive needs have always been a priority of the local care teams, but there's a need now to ensure that certain populations of youth are being reviewed by all LCTs statewide. 21, are LCTs still responsible for referrals that don't meet the criteria above and where a family is in need of community supports? You have to consider referrals for populations 1 through 6. You may continue to do what you've been doing for those other youth and families, and you can accept those other referrals as per local preference. Will this impact performance measures? There's no changes to the existing local care team performance measures. How does the requirement to hold an LCT meeting within 5 business days for certain youth correlate to the 10-day waiver? The statute, which is linked here, requires at least 10 days notice is provided for a meeting where the LCT plans to discuss a child's out-of-state placement. So if out-of-state placement is not being discussed, the notice or the waiver is not necessary. If it's applicable, certainly you should either obtain the give the notice or obtain the waiver, but not all planning or not all discussion is going to be specifically about out-of-state placement. 24, and again, nothing in the directive is meant to circumvent existing laws, policy, HIPAA, FERPA, etc. Number 24, currently with meetings occurring 1 to 2 times a month, it's people having a hard time. Again, mandated agency members need to support the process. The agencies are aware. We talked about this briefly earlier. There are no changes to the performance measures, but the data that's reported may be affected if required members don't attend scheduled meetings. Number 25, it's been stated that LCT coordinators are not case managers. However, the changes in the directive points to responsibilities that seem like case coordination, case management. No, we don't see the correlation between the new protocol that's in Directive number 3 and case management. So the local care team coordinator is managing intake, ensuring that information is received. They're documenting the LCT service planning. None of that is case management. It's all administrative. So LCT member agencies will retain their agency-specific case management and care coordination roles. So we're not expecting local care team coordinators to step into the role of agency personnel. Number 26, most of the directive is related to hospital overstays and discharge planning. Why is the LCT the first point of contact? If you have a lead agency, shouldn't these issues be addressed by the lead agencies? The Children's Cabinet has previously designated the local care teams as a central point for coordinated case management and a point of access for services for children and youth. And so it was a logical next step to enhance the role of the LCT to be that point of contact for youth populations 1 through 6. That made way more sense to expand that role versus implementing a separate but competing structure for a subset of kids. So we have a well-respected and robust structure already in place that's being supported by the Children's Cabinet. So it's only logical that we would look to that group to support this group of children as well. Number 27, what entities are considered a hospital for the purposes of these referrals? This would include private and public local general hospitals, acute care facilities, both general and psychiatric, and emergency rooms. It does not include residential treatment centers. Number 28, how are hospitals being notified and trained? The hospital discharge planning protocol was developed in conjunction, as we said, with the Maryland Hospital Association, and the protocol has been shared with them. We're reaching out to others. As I said earlier, the local care team coordinator is not specifically responsible for training or notifying hospital personnel of this, but certainly you may elect to do so if you have an established relationship with local hospitals or those personnel. It's not a requirement, but certainly feel free to do so if that meets your local needs. When will coordinators receive the Google form? Right now it's an Excel format, and we've been made aware of some fields that aren't working properly. We will get that to you as soon as we can. I personally have shifted a little bit of moving away from working on that form to try to to be as responsive as we can to get out these Q&A documents. So now that the implementation date's been pushed out a little bit, we definitely will get you that in a Google form, but right now, in the immediate week or so, we're really concentrating on responding to these questions to be responsive to you. So we will get that to you, but we don't have a date that the form will be available. In the meantime, you can continue to use your existing forms, or you can print the Excel version out if you want, or if you have an immediate need, then please get in touch with me via email and I'll help you out. Number 30, is it the role of the LCT coordinator to document that 818 packets have been sent? No, Form 818 is very specific to the Department of Human Services, and there's no requirement for local care team coordinators to use that form. So that's the first round of questions and answers that were released yesterday. As I said, we have a document number 2 that is in the pipeline right now, and we hope to get that out to you by the end of the week. That being said, I'm going to go back to Chris, and we can pick up with any questions that are in the chat. So if you have any additional questions, please put them in the chat.
If there is no lead agency and youth are in need of an RTC placement, if they don't fit the criteria for other agencies, then why are they not a DSS VPA case?
I'm going to ask one of my Department of Human Services friends to take this. Remembering you're on mute.
Thanks, Kim. Sunil?
Sorry, can you repeat the question?
If youth do not have a lead agency and are in need of an RTC placement, if they do not fit the criteria for other agencies, then why are they not a DSS VPA case?
Was there an application for VPA? Because that would be the goal. That's the goal of the VPA, is to assist a family with identifying, or assist the family with basically financial payment of that resource, whether it be a residential treatment center or right now the DDA group home placement. So if there was an application to be a VPA and there was a placement identified, that's the key in the VPA process, that there must be an identified placement for it to be approved, then that youth would qualify for a VPA.
Thank you.
Yeah, so it sounds like the answer is they may be a VPA, but they'd have to go through the process and identify a placement.
Next question. It sounds like for population number 4, this is for intensive needs rather than any needs at all. Is that correct? Can this be clarified in the directive?
Yes, it is for youth with intensive needs.
Next question. Would youth that are stuck in detention and have to be assessed for competency count as part of these populations?
Kara, you still on?
I am, but I'm just trying to get off that mute. Okay, so thanks for the question. I appreciate it, but though that's not one of the populations that's specifically outlined in the criteria. So no, that would not be one of those cases. Thank you.
What about the youth that are stuck at hospitals / RTCs because the parents don't feel that they can return home and they also feel that they need more treatment?
So this is Tennille from DHS. Then that would be where the provider, being the hospital and or the RTC, would contact the local Department of Social Services.
Thank you.
Thanks, Neil.
Why could we not have the local care team coordinators create a standard referral form that would work for all cases?
We talked about this at the local management board meeting last week. If you've got suggestions about the referral form, you're more than welcome to send those to me, this is Kim, via email. And it certainly is something that we can take under advisement when we move the form over to Google Forms.
Next question. Can submitting written recommendations serve in place of in-person attendance for the emergency, I'm guessing ER, stands for emergency room local care team, if in-person is not available for unfunded LCT members?
Sorry, Chris, that was me. Sorry. It's emergency meaning like that 5-day turnaround local care team.
Okay. So yeah, that would be subject to a local interpretation of meeting participation, and we've been very liberal with what constitutes meeting participation by the local care team members and ad hoc members that join for individual meetings. So that would work depending on how the local care team is administering its policies and procedures. And Kim, there was a follow-up question to something you covered in the question and answer recap regarding case management. And so there's some clarity here in the comments about local behavioral health agencies and core service agencies that do not have an agency-specific case management or care coordination role. Heather, would you care to kind of summarize what you added here into the chat?
Sure, and this is just a summary of a lot of our DSS folks probably saw this at the VPA Summit. And so I'm happy to reshare that PowerPoint, but local behavioral health authorities and core service agencies really serve in an administrative role in that we review and approve RTC applications for medical necessity criteria, and then a technical assistance role. So that's really more sharing expertise, knowledge, consultation, navigating the system. So while some jurisdictions do have extra funding, and so they do have staff who may help with case management and things of that nature, it's important to remember that that's an additional funding resource they have. That's not the standard for local behavioral health authorities and core service agencies. So make sure you're talking to your rep before we assume, you know, that statement about the case management role is occurring with those entities.
Thank you, Heather. Next is, how does the new directive affect the COMAR definition of local care teams?
It does not.
Next question, who maintains?
Law and regs remain as they are.
Who maintains the official record of youth at local care teams?
Do we know what we mean by official record?
Kim, this is Nancy.
Nancy, could you please add that?
I can. Just when we moved from LCC to LCT, the LMB no longer housed a formal record for cases. It remains now with the lead agency. Is that still the case?
Yes, nothing has changed there.
Okay, thanks.
How will holding these meetings reduce hospital overstays if we are experiencing overstays due to lack of bed availability or youth being rejected from all in-state RTCs because of things like an IQ under 70?
So, Kara, are we about to say something?
Yeah, I was just going to say, you know, right now, I think we kind of set up at the beginning that this group was really trying to collect data and be able to get a global scale of what the picture is and how many of those kids are there so that we are able, there was another question earlier asking about for us to be able to get more resources and additional resources. And so those referral forms and everything that you're doing helps us track that. So we're not able to, you know, we don't really have a way for all of our data to talk together. So this allows us to have that information so we're able to work together to build a continuum of services to serve all of the youth and families in the state. And so we might not be able to address that, you know, we'll be able to look at that one case, but then also gives us a larger global picture of what's happening. So I hope that helps to kind of answer that question.
Yeah, thank you, Kara.
Hey, Kim, if I could jump in real quick. I think a lot of the questions around, I understand the 5-day meeting and specifically if we have a problem, from the rejections we're getting with regard to RTCs, I think a big part of this directive is to really scale up the sense of urgency with regard to this population, and understanding we may not be able to, solve all of those issues, but the fact that we're all going to increase communication and ramp up the sense of urgency for these intensive cases, hopefully we will see some improvement. And I think that was the goal, is to see improvement while we're continuing to collect this data and see how we can, continue.
Thanks, Jenny.
Next,
Kim,
our Google form.
Kim, can I just say something for a second? I think we all want to, I'm sorry, I don't know who it was who said that we need a sense of urgency. I think we really all want to help you. The local management boards want to help you, and the local care team coordinators want to help you. I think what happened was when we looked at the memo, it felt like the whole process of local care teams were being upended, and I don't think that's true at all. And I don't think that this is a difficult to fix issue. I think we didn't understand the issues around number 4 and number 6 in the original memo. And I think Laura is trying to say that in the chat, that we just need some clarification around those youth. But I think in terms of trying to really help with this population, we're all on the same page. Our only worry was that somehow in doing that, we would upend our resources teams that have actually are working really well. So I'm just worried that this seems like we're sort of objecting to something, and we're really not at all. We're just trying to figure out how to do this and continue to serve the populations. And for us in Anne Arundel, and sorry everybody, I'm Pam Brown in Anne Arundel County, we almost never see these kids. We see families who are looking for resources, and we've had a long agreement with our DSS that we just review volunteer placements for community services, and that's it. So this is a bit of a change for us, but we're happy to do whatever we can. We're just trying to keep safe what we already have and add this piece in a right way if you want us to add it. I just don't think we really understood what was being asked of us, and I think that's really the bottom line of it. And anybody can contradict that, but I think we're getting right, and I blame myself for this. I think we're getting right into the details of this when there's a big picture here, which is about us all really being willing to be helpful. So I think if we come from that point of view, it might be easier.
Yeah, what we've been saying all along is that we're all on the same team, and this is really about getting kids the services that they needed and that they need in a timely manner. So we're going to work through this and get us all on the same page, and hopefully the Q&A documents and the information that we're putting out and these calls and future calls will will provide the clarity that's needed. So we have only about 10 minutes, so I want to try to power through as many of these questions as we can. So I'm going to say, Chris, what's the next one?
Are Google Forms HIPAA compliant?
Well, that is something that I am still researching. So I will, it's certainly, we're figuring it out. So if we find out that we're not going to be able to use that, then we'll figure out a different platform, but it's on our radar and we're working on it.
Under 1H of the Universal Hospital Discharge Planning Protocol, why are youth with complex medical needs included for local care teams? We do not have the expertise for these youth, only for youth with psychiatric features.
Again, this was protocol that was developed with input from the Hospital Association and from the agencies, and these are the youth that we're seeing that need to be identified.
And if you look at 1H is a subcategory of the broader category of youth who are in an ED for behavioral health needs or admitted to the hospital with an assessment that determines the need for residential care. So 1H is just a subset of the overall youth.
Yeah. I mean, they're
like-
intensive needs. Excuse me.
From here, it sounds like number 4 and number 6 in the original memo are the real issue. Can we limit our discussion to those?
Well, we could limit our discussion, but priorities, populations 1 through 6 are the ones that are in the Children's Cabinet Directive. So we've got, it's 1 through 6 that we're going to be dealing with moving forward.
Number 3 states that they do not have a lead agency. So why would they not have a lead?
Number 3, where? As part of 1 through 6?
That's my read, Kim, yes.
Okay, if that's the case, number 3 says they're not formally involved. That's not the same as having a lead agency or not having a lead agency. So you can have a caseworker at the Department of Social Services, but not have a lead agency identified for the purpose of residential planning yet.
Next is, will we get a copy of the questions and answers that Kim just reviewed? If you're referring to questions asked here in the chat, they will be included in a document in minutes. If you're referring to the Q&A recap and you've not yet received those, please reach out to myself or your local care team coordinator.
Yeah, that went out yesterday from Gov Delivery. So it came from it says Children and Youth Division. So make sure that you add Children and Youth Division to your safe senders or check your spam folder.
Next, and I think Pam had mentioned, can we please get revision to the language on number 4 and number 6 to reflect the clarification that these are for intensive needs youth? This will help to have this in writing for future local care team coordinators who are not privy to these conversations.
I can take that back to the larger group, but I can't commit on behalf of everybody, but we'll look into it.
Will the local care teams replace FIMS, family team determination meetings, or DSS involved youth identified in 1 through 6, or will DSS still have to do the FTDMs in addition to the LCT meeting?
So as we said earlier, that nothing in this directive, whether this directive or any of the older directives, are meant to supersede or negate any agency-specific requirements. So FIMS, those are agency specific, so you would need to check with your local DSS and DHS.
And we're getting down through to the end here. How will the referral forms help you to track this information?
Track information. I'm assuming you mean information about overstays and types of youth. It's because there's very, very specific and pointed questions asked on the referral form, such as reasons for ejection, diagnoses, all kinds of information about a specific youth and youth's needs, and that feed into resource development.
Okay,
I'll just piggyback on that. That, as Kim said, that sort of helps us to build a profile of the specific needs that youth have that we're having trouble with, and so that's the level of detail we need to take back to the Children's Cabinet so that we can all advocate for programs to meet those needs.
Thanks, Jessica.
Universal Hospital Discharge Planning Protocol E and G are typically staffed at Child Advocacy Center multi-D meetings. Will LCT still be needed if Child Advocacy Center multi-D is involved with these youth?
So the requirement is for the hospital personnel to make the referral to the local care team. If this is a jurisdiction where the local care team and a multi-D team are the same, then that would be one of those jurisdiction-specific issues we can work with you on. But if you're not the same people, then it may be duplicative, and we would want to have a conversation about that.
How will our office access data from the referral forms? I think you said that the Google Forms would be local only. I assume there is a data reporting plan based upon the referral form.
Yeah, so that would, I think we'll know more about that, how that will work once we get the forms in place and we know for sure that it is or is not a Google form. So more info to follow on that.
Does passing PHI, I assume that's personal health information, up to the IPC via the form or otherwise violate HIPAA, since the families are not present and do not provide direct consent for the passing of the information?
So you should continue any confidentiality practices that you are that you have in place. Certainly, when we have asked, or when the IPC has asked for information, we know that locals are obtaining consents, and we want you to continue to do that. The consent to release information is something that we are looking at on a statewide level. Because again, as Jessica said, having certain information helps us build these profiles about you for which resources are needed. And so that's something that we probably will have more information about, or I know that we'll have more information about in the months to come.
Thanks, Kim. And just to clarify that question, because I know you guys had asked for a lot of things, but I think families, when they're consenting to the local care team, we're not necessarily talking about passing those details up to people that aren't present in that room. So if there's an additional layer of consent for that, maybe if we could talk through that statewide would be helpful.
Okay. Yeah, we'll let you know.
Okay, we have 4 questions remaining, and we're right on a time boundary here. How would you like to proceed?
I'm okay to go through 4 if everybody, people, I mean, I want to be respectful of your time. If you need to go, then I would thank you. If not, I'm happy to stay on and go through the last 4.
Can number 6 be stated self-referrals for out-of-home placements so that we can continue to use our forms for self-referrals for community resources only?
So that's part of that. There was an earlier comment about some clarification, so we'll just lump that together.
Is the Interagency Placement Committee a recognized entity so that local care teams can modify their releases to list the IPC as a covered entity to share info?
Yes, so in the statute, there's a requirement for a state coordinating council. So the Children's Cabinet has designated the Interagency Placement Committee as the state coordinating council. So I can help you with that language, but yes, it is a recognized entity.
Another question about HIPAA and confidentiality. Would it be worth exploring the development of a secure database to house all this referral information and track each item quantitatively? Google Docs are not HIPAA compliant, says this commenter. If the office could host a secure database, they believe it would be most securely shared, stored, and reported. Just a suggestion.
Those of you,
as Kim mentioned,
like Mary Leslie, who've been around as long as I have, remember CIFIS, and our heads just blew off right now.
This is Mary. No CIFIS, please. No.
I know. I see
No.
Kathy Bowman's in front of me, and I see her laughing too. So I would put this in the parking lot, and certainly I don't have a response. This is something that we'll check into. I'm not sure how this will go. I mean, we're a week into this.
And currently the last question in the thread. Q&A recap number 30 specifies that the local care team does not need to deal with 818 packets, but a large part of this form is demonstrating the refusals, etc., from facilities. Can you clarify?
So whoever is completing the referral form, whether that's an agency person that's completing the referral form, if they want to get the information on the refusals from an 818 packet, you certainly can. We're not being so prescriptive to say from where you would get that information. However, there are other ways to get that information than from an 818 packet.
And that's the last one, Kim.
Great. So thank you all for your time and attention this afternoon. I hope this answered, I hope this provided some clarity and answered your questions. If you have additional ones, I would remind you to please send those through to Chris. And we will get cracking on the rest of the answers that we have coming forward, and we'll be in touch with more information as it becomes available.